Chapter 24, Urinary Physiology, Screencast 3. This screencast is probably covering one of the more difficult physiological concepts that we will be covering this semester. I want to be really clear about what you're responsible for, so make sure you're paying attention along the way because I'll be really pointing out what I think is important and where I probably will go on the unit exam. The first thing that we have to talk about here is a concentration gradient. And what we need to keep in mind here is this concentration gradient is present in the interstitial fluid that is surrounding the nephron. It is going to be established by primarily sodium and chloride, but we will also see that urea will play a role. What is happening here? There is a progressively increase in the concentration of solute from the cortex, and we get deeper into the medullary region. Now keep in mind, water follows solute if it can. So this concentration gradient in the interstitial fluid will exert an osmotic force to pull water into the interstitial fluid out of the nephron. And this is going to occur when ADH or antidiuretic hormone is present. Now, there's going to be two structures that we're going to address here, and they're going to have names that are very similar. The first that we're going to look at is the nephron loop. The nephron loop is a positive feedback mechanism, and it is referred to as the countercurrent multiplier. So once again, this involves the nephron loop, and here we are actually establishing the gradient. That's important. The gradient is being established through this mechanism. The nephrons that are primarily involved are juxtamedullary. Remember, they're the ones that have the nephron that goes deep into the medullary regions of the kidney. And this part here is also going to be important. The descending limb is permeable to water, but impermeable to salts. So water moves from the tubular fluid to the interstitial fluid. Salt will be retained in the tubular fluid and will become much more concentrated. Now, remember what I've said. Water follows solute if it can. This is why I have to include if it can. The ascending limb is impermeable to water, so it cannot follow the salt leaving. Salts are actively pumped out, and keep this in mind. The more concentrated the salts, the more will be pumped out. This will be happening at the beginning of the ascending limb of the nephron loop. Less concentrated salt, you will have less salt pumped out, and this is going to see what happens at the end of the ascending limb of the nephron loop. And once again, this is how we're really establishing that salt gradient in the interstitial fluid. The thing to remember here is the exchange is happening between the nephron loop and the interstitial fluid. That's important. Now, we have the vasa recta. Now, the blood in the vasa recta is traveling in the opposite direction to the tubular fluid of the adjacent nephron loop. Remember, the vasa recta are capillaries associated primarily with the nephron loop. So now we're going to refer to the vasa recta as the countercurrent exchange. Now here we're talking about maintaining the concentration gradient. That's important that we realize the difference between the two. The countercurrent multiplier is establishing the concentration gradient, whereas the countercurrent exchange is maintaining it. So now the exchange is happening between the vasa recta and the interstitial fluid. Now, water will diffuse out of the vasa recta capillaries by osmosis. Salt in the interstitial fluid will enter the vasa recta by diffusion. This increases the concentration of salt within the vasa recta. Now, the vasa recta next runs along the descending limb of the nephron loop, and the gradients are reversed, with salt diffusing out and water in. So now let's take a look at an image that is showing us this mechanism. So remember, the countercurrent multiplier is the nephron loop, and the exchange is happening between the nephron loop and the interstitial fluid. So let's kind of work our way through here. Okay, so we can see that the tubular fluid is less concentrated, as is the interstitial fluid. Notice what happens as we get deeper into the medullary regions. We actually see the interstitial fluid becoming more concentrated. So now, as we go down through the nephron loop, we hit the descending end. Remember, this is permeable to water, but not permeable to salt. So salt will stay here. And then notice how concentrated the tubular fluid is at this level. Then the tubular fluid is moving back up, and in the thick ascending limb, it is permeable to salt, but not permeable to water. Remember, salt will be pumped out of the thick ascending limb of the nephron loop. And we can see that this is how we are establishing the gradient. Now, let's take a look at the countercurrent exchange, and this is going to consist of the vasa recta, and the exchange is between the vasa recta and the interstitial fluid. At no point is there going to be an exchange between the nephron loop and the vasa recta. That's an important thing to keep in mind. Now, also notice here that we have fluid moving in the blood in the opposite direction of the nephron loop. In the nephron loop, the fluid is moving in this direction. In the vasa recta, it's moving in this direction. That's really important. So different things are happening. So as we go down the vasa recta, what is being exchanged is water leaving, and salt is actually moving into the vasa recta. As we get to the ascending limb of the vasa recta, it's going to be reversed. We now see water is actually moving into the vasa recta, and sodium is actually leaving. If this mechanism did not exist, we would actually see a dilution and loss of the concentration gradient. So the important thing to remember here is what they are doing. The countercurrent multiplier is the nephron loop and is responsible for establishing the gradient. So you need to be comfortable with what's happening in the descending limb and ascending limb of the nephron loop. The countercurrent exchange is the vasa recta. And remember, the vasa recta are capillaries associated with the nephron loop. We notice that the fluid is moving in the opposite direction, so you need to be comfortable with direction and what is moving when we talk about the descending limb of the vasa recta versus the ascending limb of the vasa recta. So what I have just addressed, and at this level, is what I will be addressing on the exam and what you are responsible for. Now, another thing to keep in mind here that plays a role in the establishment of the concentration gradient is something known as urea recycling. And what this is doing, there is a recycling of urea. About half of the solute in the interstitial fluid gradient is urea. Now, urea will be removed from the tubular fluid in the collecting duct by uniporters, okay, making its way into the interstitial fluid. It diffuses back into the tubular fluid in the thin segment of the ascending limb. It remains within the tubular fluid until it reaches the collecting duct. So here, what we're actually seeing is the recycling between the collecting tubule and the nephron loop. Now, this slide here is pretty much providing an overview of what is happening with respect to establishing the concentration gradient, and it really is primarily a summary of reabsorption and secretion. After filtration, the majority or most other substances are going to be reabsorbed or secreted. Remember, two things that are not really reabsorbed at a high level are urea, now we know why, and also potassium. Now, within the nephron loop, vasa recta, and urea recycling, this is responsible for establishing and maintaining the concentration gradient of interstitial fluid deep within the medullary regions of the kidney. Now, without this concentration gradient, ADH would not be able to do what it's supposed to. We're also looking at the regulation of various substances. Remember, this is controlled primarily by the principal cells and the intercalated cells. Then we're going to have urine at this point in time as it leaves the collecting duct. This will be composed of water, dissolved substances, waste products, It's going to be drained into the renal sinus of the kidney and eventually excreted by the urinary tract. Now, the last couple of things that we're going to talk about is measurement of glomerular filtration rate. Please keep in mind that you're not responsible for calculating this, and I'll be very clear about what I want you to understand. Now, glomerular filtration rate, the rate filtrate is formed per unit of time, and it can actually be measured with something known as inulin. This is something that is freely filtered polysaccharide, but the important thing about this is it is not reabsorbed or secreted. So urine will be collected and measured for the volume and concentration of inulin. Now, plasma concentration of inulin measured at given time intervals is going to give us glomerular filtration rate. Using this particular formula, and we are really just using it as an example. U is the concentration of inulin in urine, V is the volume of urine produced per minute, and P is the concentration of inulin in the plasma. Generally, normal glomerular filtration rate is about 125 mils per minute. When we start to see glomerular filtration rate fall below this level, we are starting to see a decrease in kidney function. Now, there are reasons why this is important. Okay. There is also something known as the renal plasma clearance test. This is another means of assessing kidney function, and it measures the volume of plasma cleared of substance in a given amount of time. If substance is neither reabsorbed nor filtered, clearance is equal to glomerular filtration rate. If substance is reabsorbed, clearance is lower than glomerular filtration rate. Once again, this sounds confusing, but let's put this concept in application. And so when we look at this, if the substance is filtered and secreted, the clearance is higher than glomerular filtration rate. But let's look at where this is applicable, especially when we look at drug clearance. And think about this. It is especially important that we know when a drug is completely out of our system, and this is going to have an impact on the dosing of that particular medication, making sure that a normal or the required amount of medication is being left in the blood to act and do its job. So drug clearance, this helps affect the appropriate dosage level to determine this. Another thing is creatinine clearance. The clearance is only slightly higher than glomerular filtration rate, and this can actually be used to approximate glomerular filtration rate. Now, this is something that we have addressed along the way, and something that I feel we are going to be encountering quite a bit of in the future. And a big part of this is due to the relationship between kidney failure and diabetes. So when we talk about renal failure, what we're looking at is a greatly diminished or complete absence of renal functions. Generally, this is due to chronic disease affecting the glomerulus or small blood vessels. One situation could be an autoimmune disease, but what we see more often are going to be high blood pressure and diabetes. The thing to remember, once parts of the kidney are destroyed, they will not function again. And when it gets to that point, there are only two main treatments. One is going to be dialysis, or the other is actually going to be a kidney transplant.